Hello everyone, today we'll be talking about cervical cancer. Cervical cancer is the third most common gynecologic cancer and the eighth most common cancer among women in the US. Mean age of diagnosis of cervical cancer is 50. However, what you need to know is that cancer can occur as early as the age of 20. The American Cancer Society estimates that in the US, 13,800 new cases of invasive cervical cancer and 4,290 deaths from cervical cancer will occur in 2020. Cervical cancer results from cervical intraepithelial neoplasia (CIN), which appears to be caused by infection with human papillomavirus, which we call HPV, types 16, 18, 31, 33, 35, or 39. So you need to know the types because there are different types such as type 6 and 11, which actually cause genital warts, okay? So the ones that cause cervical cancer are type 16, 18, 31, 33, 35, or 39. Risk factors of cervical cancer include younger age at first sexual intercourse, high lifetime number of sex partners, cigarette smoking, immunodeficiency, and regardless of sexual history, clinicians should always assume that women have been exposed to someone with HPV because it is ubiquitous. So when we talk about cervical intraepithelial neoplasia, the pathology is we put it in three stages, okay? So one is mild cervical dysplasia, two moderate dysplasia, three severe dysplasia, and carcinoma in situ. So when we say carcinoma in situ, we're basically saying that it hasn't yet breached the basement membrane. And when we get to CIN3, this is unlikely to regress spontaneously. So if it's not treated, it may over months or years penetrate the basement membrane and become invasive carcinoma. So when we talk about the pathology of cervical cancer, about 80 to 85% of all cervical cancers are squamous cell carcinoma. And the rest are adenocarcinomas, sarcomas, and small cell neuroendocrine tumors, which are rare. Invasive cervical cancer usually spreads by direct extension into surrounding tissues or via the lymphatics to the pelvic and para-aortic lymph nodes. However, you need to know that heterogeneous spread, it is possible, however, it's rare, okay? So the most common way of spread is via direct extension into surrounding tissues or via lymphatics, okay? If cervical cancer spreads to the pelvic or para-aortic lymph nodes, the prognosis is the worst, and the location and size of radiation therapy field is affected. Then when we talk about the signs and symptoms of cervical cancer, the most common findings in patients with cervical cancer is an abnormal pap smear result. So the physical symptoms of cervical cancer may include the following: abnormal perivaginal bleeding, vaginal discomfort, malodorous discharge, dysuria. However, what you need to take note of is early cervical cancer can be asymptomatic. So when symptoms occur, they usually include irregular vaginal bleeding, which is most often postcoital, but may occur spontaneously between menses, so intermenstrual bleeding, postcoital bleeding. Then larger cancers, they are more likely to bleed spontaneously, and they may also cause a foul-smelling vaginal discharge or pelvic pain. So you need to ask, so when a patient comes, you need to ask about urinary symptoms, you need to ask if they're having any abnormal bleeding, postcoital bleeding, intermenstrual bleeding, or any spontaneous bleeding, okay, from the vagina. Then more widespread cancer may cause obstructive uropathy. They may present with back pain, leg swelling due to venous or lymphatic obstruction. Then when you do a pelvic examination, you may detect an exophytic necrotic tumor in the cervix. In physical examination, so in patients with early stage cervical cancer, physical examination findings can be relatively normal. As the disease progresses, the cervix may become abnormal in appearance. With gross erosion, ulcer, or mass, these abnormalities can extend to the vagina. Then rectal examination may reveal an external mass or gross blood from tumor erosion. When you do a bimanual pelvic examination, findings they often reveal pelvic or perimetrial metastasis. If the disease involves the liver, hepatomegaly may develop. Pulmonary metastasis usually is difficult to detect on physical examination unless pleural effusion or bronchial obstruction becomes apparent. Like edema suggests lymphatic or vascular obstruction caused by tumor. So far we have discussed the signs, the symptoms of cervical cancer, the causes. Now let's go to the diagnosis. So diagnosis of cervical cancer, you can do a pap smear or the pap test, you can do a biopsy, then staging, okay? So diagnosis of cervical cancer. So cervical cancer may be suspected during a routine gynecologic exam, and it's considered in women with 1. Visible cervical lesions, 2. Abnormal routine pap test results, 3. Abnormal vaginal bleeding, okay? Approach considerations. So complete evaluation starts with the pap test. Positive results should prompt colposcopy and biopsies, with further workup of cervical intraepithelial neoplasia (CIN), including excisional procedures. Then, if pathological evaluation after loop electrosurgical excision or conization suggests invasive cancer with positive margins, the patient should be referred to a gynecologic oncologist. Patients with suspicious or grossly abnormal cervical lesions on physical examination should undergo biopsy regardless of the cytologic findings, okay? Then once the diagnosis is established, a complete blood count, serum chemistries for renal and hepatic function should be ordered, okay? To look for basically abnormalities from possible metastatic disease. And imaging studies should be performed for staging purposes. Then in the FIGO guidelines, for staging procedures are limited to the following. So let's go through this. So a colposcopy, biopsy, conization of the cervix, cystoscopy, proctosigmoidoscopy, chest x-ray. So we can talk about this in more details in another video. So staging of cervical cancer. So we start all the way from stage 0 to stage 4B, okay? So when we talk about stage 0, we have got carcinoma in situ, which we call CIN. Then stage 1 is where invasive carcinoma is confined to the cervix, diagnosed only by microscopy, okay? So when we talk about 1A1, there is a microinvasive carcinoma with stromal invasion of less than 3 meters depth and less than 7 millimeters width. Then stage 1A2, microinvasive carcinoma, less than 5 millimeters in depth and less than 7 millimeters in width. Then stage 1B, clinically visible or microscopic lesion of greater than 1A2. So 1B1. So if you take note of it, in 1A we talk about microinvasive, okay? However, in 1B we talk about clinical lesions. So clinical lesion of less than 4 centimeters, and 1B2, clinical lesion of greater than 4 centimeters. Then stage 2, extension beyond the cervix but not to the side wall. So 2A is involvement of the upper 2/3 of the vagina, and 2B is parametrial involvement. Then stage 3, extension to the pelvic wall and or lower third of the vagina, or hydronephrosis. So 3A is involvement of the lower third of the vagina, and 3B is pelvic sidewall involvement or hydronephrosis. Then stage 4 is where there is extension beyond the true pelvis or involving bladder or rectum. 4A, involvement of the bladder or rectal mucosa. 4B, spread outside the true pelvis or metastasis to distant organs. So when we talk about screening recommendations for specific patient groups are as follows. So 21 to 29 years of age, cytology or pap smear alone every 3 years, okay? So if it's normal, you repeat it after 3 years. Then 30 to 65 years, you can do a HPV testing and cytology co-testing every 5 years, which is preferred, or even cytology alone every 3 years is acceptable. Then if they're above 65 years, no screening is recommended if adequate prior screening has been negative and high risk is not present. So I want to talk about the prognosis of cervical cancer. In squamous cell carcinoma, distant metastasis usually occurs only when the cancer is advanced or recurrent. And the 5-year survival rate is as follows. So stage 1, it's 80 to 90%, which is quite good. Stage 2, 60 to 75%, which is moderate. Then stage 3, 30 to 40%, which is quite low. Then stage 4, the survival, 5-year survival is 0 to 15%. Then nearly 80% of recurrences manifest within 2 years. So adverse prognostic factors for cervical cancer include 1. Lymph node involvement, 2. Large tumor size and volume, 3. Deep cervical stromal invasion, 4. Parametrial invasion, 5. Lymphovascular space invasion, 6. Non-squamous histology. So treatment of cervical cancer. So surgery or curative radiation therapy if there is no spread to parametria or beyond. 2. Radiation therapy and chemotherapy. This is recommended if they spread to the parametrium or beyond. 3. Chemotherapy for metastatic and recurrent cancer. 4. Treatment of cervical cancer. It may include surgery, radiation therapy, and chemotherapy. If hysterectomy is indicated but patients are not ideal candidates for it, chemoradiation is used and it has similar oncologic outcomes. So now let's talk about treatment specific to the stages. So stage 1A, where there is no lymphovascular space invasion, you can do conization or simple hysterectomy. Then, microinvasive cervical cancer defined as FIGO stage 1A1 with no lymphovascular space invasion has a less than 1% risk of lymph node metastasis, and it may be managed conservatively with conization using LEEP, laser, or a cold knife. And simple hysterectomy should only be done if patients are not interested in preserving fertility or if margins are positive after conization. Then stage 1A1 with lymphovascular space invasion and stage 1A2, you need to do a modified radical hysterectomy and pelvic lymphadenectomy and external pelvic radiation therapy with brachytherapy. Then for stage 1B1, 1B2, and 2A1, the standard recommendation is open radical hysterectomy with bilateral pelvic lymphadenectomy. Then stage 1B3, 2A2, 2B, 3, and 4A. Standard therapy is external pelvic radiation therapy with brachytherapy and concurrent platinum-based chemotherapy. And surgical staging may be considered to determine whether para-aortic lymph nodes are involved and thus whether extended field radiation therapy is indicated, particularly in patients with positive pelvic lymph nodes identified during pre-treatment imaging. Then when cancer is limited to the cervix and or pelvic lymph nodes, standard recommendation is external beam radiation therapy followed by brachytherapy to the cervix. 2. Chemotherapy using cisplatin or carboplatin is usually given with radiation therapy, often to sensitize the tumor to radiation. Then, although stage 4A cancers are usually treated with radiation therapy initially, pelvic exenteration, which is basically excision of all pelvic organs, may be considered. If after radiation therapy cancer remains but is confined to the central pelvis, exenteration is indicated and it cures up to 40% of patients. Then stage 4B and recurrent cancers, chemotherapy is the primary treatment and response rates are about 48%. Then metastases outside the radiation field appear to respond better to chemotherapy than this previously irradiated cancer or metastasis in the pelvis. So summary, cervical cancer is usually a squamous cell carcinoma caused by HPV infection. Less often it is an adenocarcinoma. Cervical neoplasia is asymptomatic, that's why we recommend routine screening. The first symptom of early cervical cancer is usually irregular, often postcoital vaginal bleeding. Diagnosis is by a cervical papillomavirus test and biopsy. Staging is clinical combined with imaging and pathology results when available. And treatment usually involves surgical resection for early stage disease or radiation therapy plus chemotherapy for locally advanced disease. If the cancer has widely metastasized, chemotherapy is often used alone. Then consider cervical cancer if women have abnormal pap test results, visible cervical lesions, or abnormal, particularly postcoital vaginal bleeding. Do a biopsy to confirm the diagnosis. Then stage cervical cancer clinically using biopsy, pelvic examination, and available imaging that can include chest X-ray, and if the stage is more than 1B1, using a PET scan, CT scan, MRI, or CT to identify metastasis. Treatment is surgical resection for early stage cervical cancer, radiation therapy plus chemotherapy for locally advanced cancer, and chemotherapy for metastatic and recurrent cancer. Screen all women by doing PAP and HPV tests at regular intervals, just 3 to 5 years, and also recommend HPV vaccination for girls and boys. So that's all about cervical cancer. If you have any questions, please feel free to comment, like the video, and subscribe to my channel. Thank you.